So our objectives are to describe the etiology, the patho, the manifestations, collaborative care, and nursing interventions connected to COPD and asthma. We're also going to describe the effects of cigarette smoking on the lungs. The scary thing about COPD is that the incidence is climbing at an alarming rate. Right now, it's one of the top 5 leading causes of death. And it can lead to multiple comorbidities, okay, including pulmonary hypertension, which is cor pulmonale, and we'll talk about that here in just a minute. You'll also hear the term chronic bronchitis or emphysema. A lot of folks will use those terms interchangeably when they're talking about COPD. It's kind of like the umbrella of the COPD world. Well, what are some of the risk factors for COPD? Well, the number 1 risk factor is smoking, okay? Some of the other factors include low socioeconomic status, advanced age, recurrent or chronic lung infections, environmental exposure or occupational exposure, or some individuals are just have bad genes and they're missing a particular phenotype that kind of puts them at a higher risk level to eventually get COPD if they're kind of doing certain activities or certain habits that put them in that higher risk level. Okay. All right. So obstructive pulmonary disease basically is a progression. Okay. One that cannot be reversed. So if you can think of it at one point where you start to have some mild inflammation, some mild narrowing of those airways, and you start to have a lot of mucus built up. Eventually, all of those mucus plugs and the narrowing of those airways trap air. So basically what happens is that anytime you have an inhalation or an exhalation, your body's not doing exactly what it's meant to do. It's not really sort of emptying the lungs, so to speak, of during that expiration of air, right? So what happens is that you really have a hyperinflation on expiration. And we'll kind of talk about that here as we go through some more of the pictures, okay? So really, as I said, you have irreversible structural damage to the alveoli, okay? That in itself decreases the elastic recoil and reduces the airway diameter due to chronic inflammation. And therefore, so now your alveoli are even smaller, okay? And they're not being able to do what they're meant to do, right? Because that's where your gas exchange takes place, okay? So your airway sacs are smaller. They have almost like a thickening of the membranes, and all of that results in poor gas exchange. The key here is the chronic inflammation. Once again, it cannot be reversed. Kind of an easy way to think about it is changes in those small airways equals chronic inflammation, which equals chronic airway remodeling. So your entire pulmonary system is being remodeled due to this, due to the changes in the small airways. So one thing that can be confusing for a lot of students is what is the difference between obstructive lung disease and, say, restrictive lung disease? So obstructive versus restrictive. Obstructive is really the difficulty with exhaling air, so difficult exhalation, and that's what you get when you have asthma and COPD, okay? Once again, the obstruction can occur when the inflammation and the swelling cause the airways to become narrowed or blocked, and that's what makes it difficult for the air to be difficult, well, actually for the difficulty in expelling air from your lungs, okay? This really leads to an abnormally high volume of air being left in those lungs, okay? Like I said, your lungs aren't really deflating the way they should, okay? This leads to that air trapping, okay? Restrictive lung disease is a difficult time filling up the lungs with air during inhalation. Okay, so you have a decrease in the total volume of air that the lungs are able to hold, and that's due to the elasticity of the lungs. Okay, that's pulmonary fibrosis. That's something different. Okay, so we're not going down there. We're only talking about obstructive. We're talking about COPD and asthma. Okay. One term that you might hear along with COPD is that chest barrel, the barrel chest individual, and that is caused by having too much air trapped in your lungs, right? So if you can look at this picture and you see this gentleman, he's just kind of almost doing like a tripod over the bedside table because he's working so hard to breathe. His muscles, he's using all of those accessory muscles to breathe. And so you can almost see that barrel chest if you kind of picture that alongside that table there, okay? A couple things I'll point out with this picture are the digital clubbing, okay? Why does this picture dictate digital clubbing? Well, that's caused by chronic low levels of oxygen in the blood, okay, which we all know is hypoxemia, okay? All right, let's look what else we have here. So this gentleman is also easily fatigued. He has frequent respiratory infections because he can't cough out all of this nasty gunk that's in his lungs, okay? He's thin in appearance because he is working so hard to breathe. They just crave massive amounts of food, but they can't seem to get enough because the body is working so hard to breathe. Of course, dyspnea, he's wheezing, he has pursed lip breathing, and we'll talk about that. That's a chronic thing that you see a lot of COPDers use to help them breathe a little bit easier. And typically when you see these patients, it's really the dyspnea that brings them in. It typically starts with just general exertion and progresses to constant dyspnea. And then it just basically interferes with their daily life. So let's talk a little bit more about dyspnea from COPD, okay? Obviously, you pretty much know the answer to this question on this slide. Are they efficiently or inefficiently breathing? Well, they're not efficiently breathing, okay? The little air sacs in their lungs, they're distended, they're trapping air. The diaphragm can flatten from hyperinflation. They have a constant increased use of accessory and intercostal muscles. All of these things are making it very, very inefficient for them to breathe. What are some of the classic signs of manifestations of someone that has COPD? Well, tremendous weight loss, anorexia, fatigue, anxiety. Those are things that I just mentioned on the previous slide. They could have some pretty severe depression, right? They're having huge changes to their daily life, and the changes are obviously not positive, okay? They also have hypoxemia and hypercapnia. Also polycythemia. Why? Why do they have polycythemia? Well, what is it? Do you recall what it is? Polycythemia is increased red blood cell production, okay? And basically that's the body, that's happening because the body is trying to get more oxygen filtrating through, okay? That's what's happening. So you have that much higher red blood cell count. Okay, so let's talk about cor pulmonale, okay? We already just said that with polycythemia, you have an increased red blood cell count, okay? But let's really get down to the bare bones of that. When you have a higher red blood cell count, an increased red blood cell count, that really increases the viscosity of the blood, right? It makes it really thick, okay? And I hopefully you're thinking what I'm thinking, okay? When you have that very thick blood, you're more apt to have a lot of remodeling, a lot of vasculature remodeling, okay? So with cor pulmonale, let's talk about what it is. It's really an enlargement of the right ventricle, okay, which is caused by that vascular remodeling through the viscosity of the blood, that increased viscosity of the blood, okay? And you see this picture here, you see all of the things that happen when this starts to happen, this right-sided heart failure, cor pulmonale, okay? You have massive fatigue, you have increased peripheral venous pressure, you could have ascites, you could have an enlarged liver and spleen, tremendous weight gain, distended jugular veins. Everything is backing up, right? You can get dependent edema on lower extremities. It's very, very telling when you see patients that have right-sided heart failure, okay? Some of the management with this is oxygen, of course, and sodium-restricted diet, and very, very specific drug therapy. So just to kind of recap, okay, right-sided failure, you've looked at all the different signs and symptoms of a patient that has that, okay? You can see here what some of the management is that's involved. But let's just make sure we truly understand what's causing what, okay? So you have an increase in pressure that causes lots of strain on the heart's right ventricle. So as that works, it's trying to pump blood through the lungs, and it can't do it the way that it should, okay? So that's why all of these things are happening. All right, diagnosis. Well, what is the diagnosis of COPD? Okay, well, there's a bunch of different tests that they can do. The biggest one is the pulmonary function test. And as you can see here, it's a patient right here. She's blowing into the machine. Basically, she's blowing to try to figure out how much she is able to exhale, right? Okay, those are called pulmonary function tests. The goals of the treatment are obviously more time without some of the symptoms, improved quality of life. You want them to be more engaged, hopefully feel better, have less depression, some symptom relief, more activity, okay? Those are really the goals of treatment, because remember we said that there's no cure, okay? It's all about trying to treat what is in front of us and helping the quality of life of our patients. Medications. I've said before that this is not a pharm class, but it is important for you to understand some of the key medications that are used for COPD, okay? One of the things that we're going to be talking about in just a little bit here are inhalers. So we will be talking about inhalers, more specifically about asthma, but for right now, I just want you to be aware that for COPD, we're going to be talking about inhalers as well as oral and inhaled corticosteroids, okay? So it's a combination of things. It's oral medications and inhaled medications for COPD. It's a combination of both. Some of the collaborative interventions, let's talk specifics here, okay? These are the things that we're going to hopefully be teaching our patients, and hopefully these things are going to make a difference in their lives. Smoking cessation. We're going to encourage them to have an exercise plan, okay? We're going to teach them how to do pursed lip breathing, okay? Who knows what pursed lip breathing is? Kind of think about it, okay? It's going to force them to have prolonged exhalation. Okay, that is going to help minimize or hopefully even prevent some of the air trapping and the bronchial collapse that happens with COPD folks. Okay, so pursed lip breathing, that's breathing, kind of retraining of breathing. Okay, we're also going to talk to them about airway clearance techniques. Okay, nutrition. We want them to have small, frequent meals, high calorie. Okay. Because they're burning so many calories just to try to breathe. Oxygen therapy, okay? You know, oftentimes you'll hear a lot of orders that say keep oxygen sats above greater than 94%. Well, when you have folks that are so used to oxygen levels being low, if we give them too much oxygen, then their body doesn't want to do what it should do, okay? So not to get into too much terminology, but right now we're just going to say for COPDers, we really want to keep their oxygen therapy no greater than about 90%, okay? That's at rest. We've already said there's no cure. We want to help prevent falls and make sure that they have follow-up appointments. As the disease progresses, poor outcomes become very, very prevalent. I almost forgot to mention in particular about the airway clearance techniques. One of the things that's super important for you to understand is huffing. I don't have this on the slide, but I do want you to be aware of it. Huffing is called like huff coughing. Basically, when patients cough, it forces mucus up. So we teach them to take a nice big deep breath in, hold it, and then they exhale forcibly. And that really, really helps to get some of that mucus up, okay? So two big things here, pursed lip breathing and huffing or huff coughing. Okay, let's move on to asthma. I would be surprised if one of you all didn't have it, or if you know of someone that has it, a loved one, a friend. It's very, very common. Millions and millions of Americans have asthma. Basically, it's a hyper-responsive airway inflammation, okay, of your airways, the bronchi and the bronchioles, okay. I can remember many, many years ago, there used to be a commercial about asthma, and they would have a fish that was out of water, out of his goldfish bowl, and they interviewed patients that had asthma, and they said that's what it felt like. If you could imagine being a fish and being out of water, and the water was the way that you breathed, right? And so that's what asthma apparently feels like. Fortunately, I don't have it. I'm very, very grateful, but that is kind of what I understand that it feels like. How does asthma work? Well, basically what happens, so basically with asthma, you can have an inflammation of your airways, okay, that temporarily causes the airways to constrict, and you can't breathe, and that's what causes the wheezing and the increased work of breathing. And medications and certain activity, those kinds of things will help or hinder asthma symptoms, and we're going to go into that just here in just a little bit. Just as a fun fact, not even really fun, but a fact, female African Americans have the highest mortality rates from asthma among all ethnic and gender groups. Something to be aware of. What are the risk factors and triggers of asthma? Genetics, immune response, allergens, exercise, air pollution, occupational and environmental hazards, respiratory tract infections, nose and sinus problems, drug and food additives. GERD is a huge, huge trigger for asthma. Obesity is also big, okay? Those are some ones I really, really want you to focus in on, okay? Specifically GERD and obesity and allergens, those three, okay? So let's talk about asthma triggers. The book goes into this, and it's super important. What is the asthma triad? I'm not sure if you guys have ever heard of that before, but it's basically the perfect storm, okay? If you have a patient that has nasal polyps, that has a lot of skin reaction or skin rashes, and a sensitivity to aspirin and or NSAIDs, that is the perfect storm for asthma. Okay, those are the folks that are most likely to have asthma, and that is the asthma triad. Another trigger for asthma is GERD, okay? Basically, you have that chronic acid that's coming up from the stomach, and it causes that inflammation and irritation, and that is which causes bronchoconstriction and could possibly cause aspiration. Okay, so that's the correlation between GERD and asthma. Okay, that constant triggering of constriction and possible aspiration. Okay. So what do you think are some of the clinical manifestations of asthma? You guys pretty much know these, but let's just review them, okay? Wheezing, cough, dyspnea, and chest tightness. Those are the things that you hear most likely from patients that have asthma, okay? Expiration may be prolonged, okay? They're just trying to get their breath. They're trying to just to really try to move that air as much as they can. Okay. It almost feels like they're suffocating at times, just kind of like that goldfish that I described. What are the diagnostic studies for asthma? Well, you have a peak flow meter, and that's really what this picture is. So we're going to talk about a peak flow number here in just a minute, but that is one of the big things that that's basically used to help asthma patients manage their symptoms, is a peak flow number. Okay, sort of like if you can think of a peak flow meter, sort of like the blood pressure cuff that checks your blood pressure, but a peak flow meter checks your asthma. Okay. So in addition to that, the studies include history and exam, pulmonary function tests, chest x-rays, ABGs, allergy testing, sputum cultures, okay? Asthma treatment, really your goal is to try to have as normal of activity level as you want. Achieve and maintain control of the disease, okay? Classifications are based on severity. We're going to talk about the medication regimen here in just a little bit. And then what is the most effective drug class to treat the inflammation that is caused by all the allergens in the air that cause asthma? Those are the inhaled corticosteroids. That is going to be the most effective drug class to treat the inflammation that is basically triggering that asthma. Let me backtrack a little bit here on this peak flow meter. How does it work? Well, basically the patient puts the mouthpiece to the mouth. They press down. They kind of press down. Press the flow, kind of like the mouthpiece, into the mouth, and then they blow as hard as they possibly can. And then you can see the little numbers on the side there. These numbers will give them a meter reading. Okay, that's kind of how that works. Okay, so let's talk about asthma drug therapy. Okay, you have SABAs and LABAs. Okay, SABAs short acting, and then LABAs long acting. Okay. So let's assume you have a patient that's having a asthma attack, okay? We want to provide them with the fastest relief, bring quick relief, okay? So we're going to grab an inhaler, okay? We're going to grab possibly ProAir or albuterol. Those are your quick-acting inhalers, okay? You see this female patient to the far left. She has what's called a spacer that's behind the inhaler that allows for all the medication to get in as best as possible. It just kind of holds all the medication in that chamber, for lack of a better word, and then she can inhale it that way, okay? And then let's just say you've got it under control at that point, and they're starting to feel a little bit better, and the patient may need several more doses of that inhaler if they're having a really, really bad asthma attack, okay? So let's just stop there. So we've brought the quick relief, and now we're going to talk about daily control and how we're going to maintain our activity levels, what we want to do, and also reduce that inflammation. So it could be a combination of oral corticosteroids or inhaled corticosteroids. Okay, combination of things. So combination drugs, the short-acting, long-acting, inhaled corticosteroids. It's a combination of things. The table in your book goes into some pretty significant depth about it. What I do want to point out to you, and you will be responsible for this, is in particular how you're going to read an asthma action plan. Well, first, this is just the stepwise approach here. Let me flip to the next slide. This is the asthma action plan, okay? You have a green zone, a yellow zone, and a red zone. Green is that your patient is doing well, and their peak flow is the number where they are at their best, okay? So let me kind of backtrack a little bit. When you have a patient that has asthma and you're trying to figure out where they need to be in terms of an asthma action plan, and the action plan is really how they're going to be treated at home and or in the doctor's office, okay? So a patient will need to first use a peak flow meter. I almost forgot the word for a moment. A peak flow meter. When a patient's feeling very, very good, they use the peak flow meter to determine what level they are at that very moment. So they're at their personal best, hopefully at that moment where they're getting that peak flow number, okay? So the peak flow number is usually 80%, at least 80% or greater of their personal best, right? They have no symptoms. Things are going great. Asthma is not affecting them in any way, shape, or form. They're doing great, okay? That is their very, very personal best, and they've got that number from the peak flow meter, okay? And then let's say a week later, they start to feel kind of lousy, right? They start having coughing and wheezing, shortness of breath, or chest tightness, and they do their peak flow. Well, it's only 50% of what they just had at a week ago from their peak flow meter. So the peak flow number could be between 50 and 80% of that personal best. So they're a step lower in terms of how well they're doing than they were a week ago. Okay, so based on that number, the doctor will prescribe a certain number of medications or a particular kind of medication for them, okay, if they end up in that yellow zone. Okay, the yellow zone is the caution zone, okay. Red zone, let's talk about the red zone. The red zone is the danger zone. This is when a patient is having a horrific asthma attack. They are having constant coughing or wheezing, just a horrible time breathing at rest. They're having severe symptoms. They've probably called 911. If they don't have their rescue inhaler nearby, they are in sad shape. If they were to do a peak flow reading, at that point they would find that their peak flow is less than 50% of their personal best, which was at the green zone. Okay, so it's important for you to understand what an asthma action plan is, and in particular what each zone is telling the patient where they're at. Okay, green zone, they're greater. They're at least 80% of their best. Okay, yellow zone, 50 to 80% of their best. Red zone, 50% or less of their best. Okay, and then I want you to understand the difference between the short-acting, so very short-acting rescue inhaler like albuterol versus a long-acting inhaler or a long-acting corticosteroid that a patient would take on a daily basis to maintain how well they're doing with their asthma. Okay? All right. Acute asthma attack. These are the symptoms that you're going to find: increased restlessness, anxiety, increased heart rate, blood pressure, respiration rate. They could be diaphoretic. They are so short of breath, they are having a hard time speaking in full sentences. They may be in a tripod position. Anything